A very classical symptom that patients with SLE come to us is the malar rash, the rash over the face, what we call the butterfly rash. In fact, it is this butterfly rash that is so classical that if you look at this rash, one can easily diagnose SLE. However, these patients can have several other problems: significant hair fall, repeated ulcers in the mouth, vague aches and pains. Sometimes their joints are swollen, what we call arthritis. As I mentioned before, this disease can affect any organ of the body, and kidneys are a common target. I would say almost 30 to 50% of patients may end up getting a kidney problem where the kidneys are being attacked by the autoimmune disease. And we call it the lupus nephritis. And other organs that can be affected, especially bloodlines, can be affected. And when blood cells are affected, we see these patients having very low hemoglobin, sometimes very low platelet counts and white cell counts. And occasionally the brain can be affected, and even intestines can be affected. A subgroup of these patients have increased risk of blood clotting. And if they have a clot in the blood, they can develop something like stroke in the brain. And these patients with SLE who have increased risk of clotting, we always look at a group of antibodies which are called the anti-phospholipid antibodies. So any patient with SLE, we routinely test them for this risk of clotting. No two patients of SLE look alike. There may be a patient who just comes with a malar rash and does not have kidney involvement, and there could be a second patient who just comes with severe kidney involvement, severe kidney problem, but does not have the classical malar rash. So, and there may be one patient who just comes with sudden fall in platelet count and what we call the autoimmune thrombocytopenia. And that is why these patients may not be diagnosed in time. In clinical practice, we see anywhere between 6 months to 12 months is the average delay in diagnosis before these patients are really diagnosed. Now, there are several criteria in clinical practice that we use to diagnose these patients. There is something called the SLE classification criteria for this is the SLIC criteria, the Systemic Lupus International Collaborating Clinics criteria. Now, these criteria help a clinician to diagnose these patients. However, for an expert who is routinely involved in care, all these criteria need not be satisfied. Now, once I see a patient with suspected lupus in my clinical practice, I would like to do some specific tests. Apart from doing the routine blood tests that we do in all the patients, like we would like to look at their hemoglobin, platelet counts, their kidney functions, liver functions, there are some specific tests that we do to diagnose lupus. And one of them is the anti-nuclear antibody test. Now, this anti-nuclear antibody test, which we also call the ANA test, is a screening test for the diagnosis of lupus. We call it the screening test because more than 99% of our patients will be positive for this test. However, one must remember that 5% of healthy people can also be positive for an anti-nuclear antibody. So what does this tell us? That just having a ANA positive test does not mean you have SLE. ANA is one test that can be positive in several conditions. It can be positive in infections, it can be positive sometimes in cancers, it can be positive in other autoimmune diseases. So whenever you are asked for an ANA, it does not mean you are getting the final diagnosis. However, if you have a very strong suspicion of SLE and we get an ANA test, and if it comes positive, then we do some confirmatory tests like a detailed ANA profile and then a long list of tests that help us confirm the diagnosis of SLE. And once we confirm the diagnosis of SLE, we always make a point to understand how severely is the patient affected. Because as I mentioned, no two patients have the same disease. And that is why we always make a point to see whether kidneys are affected, whether any internal organs are affected before we start the treatment. And once the diagnosis is established, we then go ahead with counseling the patient and treating the patient. Now, before I start talking on treatment, let me briefly touch upon what really causes the disease. I'm sure the viewers must be wondering what caused this disease called SLE. Now, let me tell you, as per medical literature, the cause is not known. We do not know why some people develop autoimmune diseases. However, there are theories that say both genetic factors and environmental factors can be taken into consideration, and some people who have genetic predisposition and particular environmental exposures may end up developing SLE. But what is well known is that when children develop SLE, especially before the age of 5, we should always look at the genetics, because there can be single gene defects like monogenic diseases that can present with SLE in very young children. Now, coming to the topic of pediatric SLE or childhood lupus, because I'm particularly dealing with children. So the first question I would like to answer is lupus in children different from adults? Well, the most common manifestations, the classical presentation, the testing strategy essentially remains the same. However, SLE in children is very severe or typically more severe when compared to adults. For example, the risk of development of a kidney involvement, severe nephritis, is much higher in children compared to adults. And as I mentioned before, if I see a very young child with SLE, I would like to do a genetic test. One of the common conditions amongst these genetic forms of lupus is the complement C1q deficiency, which we have diagnosed a few patients in our practice. When you see an adult physician treating a patient with SLE, they will never do a genetic test. But as pediatricians, in young patients, we do genetic testing.